Excellent. Well, welcome everybody to our MEP Pop Up Learning session. It's been quite some time since our last Pop Up Learning. We've covered a lot of ground, and just to look back in retrospect, in terms of how much we've covered and how far we have come since we first started these pop-ups back in the March timeframe. So we'll just go ahead and do a quick round of introductions and just name and your role within MEP or MedStar, and any conflicts of interest or disclaimers. Manish, we'll start with you.
Hey everyone, I'm Manish Goyal. I'm the Director of Faculty Education and also Chair of the IRB, and I work clinically at the hospital center.
Great, welcome. Mike Ybarra.
Hey everyone, Mike Ybarra. I'm one of the attendings at Georgetown, and I'm also Vice President at Pharma. So that's my conflict of interest, although Pharma is not a commercial interest. Pharma is a trade association, but we represent companies like Pfizer, Merck, Genentech, J&J that do have commercial interests.
Great, thanks, Mike. Carrie.
Hi, I'm Carrie Lehman. I'm the Clinical Chief of Emergency Medicine at Georgetown. I'm also the co-chair of the MedStar Emergency Physicians Quality and Safety Committee.
Great, welcome, Carrie. Rory. I think Rory might be frozen. We'll circle right back to Rory.
Oh, sorry, no.
There you go.
I'm back. Sorry, you were just breaking up for a sec. I'm Rory Spiegel. I'm one of the co-chairs of the critical care section at MEP. And clinically, I work 50% of my time in the ED and 50% up in critical care department.
Great, welcome, Rory. Matt Wilson.
Hey, Matt Wilson, Vice Chair at Washington Hospital Center. Was fielding a lot of questions about clinical care and vaccines and offered to look into it, and have been happy to join the team and have some experts joining us too.
Great, thank you, Matt. Kate Kellogg.
Hi, everybody. I'm Kate Kellogg. I work clinically at the hospital center, and I am also the Assistant Vice President for Quality and Safety for the system. And in COVID days, I helped to support running the clinical side of the COVID response for the system, including infection prevention.
Great. And Kate, if you could also, I don't see Terry on the line, but I think he may be joining us. So if you can just give a quick blurb on Terry's behalf, that'd be great.
Absolutely. And he may or may not jump on. We have a lot going on today with the kickoff of the vaccine. So we're juggling a bit. But Terry, if he jumps on, Terry also works clinically at the hospital center. He's the Vice President for Quality and Safety. And our team, again, we're kind of running this COVID response. So we'll see if he can jump on. We're dividing and conquering a lot today.
Great. No, completely understood. Thanks so much, Kate. And myself, Jonathan Davis, I'm the Academic Chair for Emergency Medicine. No conflicts pertaining to this call at all. And we'll just launch right into it. And so we're going to start off with vaccinations. Then we're going to move into the foundations of ED evaluation. And then finally, we're going to round it out with the critical care aspects that are important to our ED evaluation and the next steps in care in that relay of care. So starting off with vaccines, a lot in the news, a lot happening within our health system and nationally, as we've seen. So we'll start with you, Dr. Ybarra. So if you can lead us off.
Yeah, totally. Thanks for having me. Let me try and share my screen and I can put up a couple of slides. Give me 1 second. See if I can make this work. You'd think I'd be a Zoom expert by now. All right, can you see?
Looks great, Mike.
Okay, perfect. All right, well, thanks everyone for having me. As I said, I'm one of the attendings at Georgetown. I've been at Georgetown since 2011. I also did my residency there, and then I went to medical school also. So I'm a bit of a lifer. Both of my kids were born at Georgetown in 2012 and 2014. I am not, however, a virologist. I don't have any special medical training in vaccines, but I think my background working at pharma, I've been at pharma for 6 years as a vice president of medical affairs there. We're the trade association that represents the innovative biopharmaceutical companies like Pfizer that have come up with this vaccine, in addition to a number of other companies. I'm also a participant in a clinical trial. I'm in one of the vaccine clinical trials. I am in the Moderna trial. I've got 2 shots, one in August, one in September, of an experimental vaccine. It's not yet been authorized by the FDA, But I'm really, excited to kind of share that perspective as well. And because of those two things, I think I've really tried to immerse myself in every little piece of literature that there is on the vaccines, because I was interested in what it was doing to my body. And then also from the pharma perspective, what industry is doing on the COVID-19 front. So from an industry perspective, we've been doing a ton of tracking of public opinion research on COVID-19 vaccines. And what we know is there is a large but kind of shrinking minority of the public that says they're hesitant about taking the vaccine. A pop-up poll today showed that the hesitancy has declined to about 20%. So 1 in 5 people saying that they're concerned about the vaccine. And it's interesting that if you break out the data, women are more likely than men to have concerns. And then individuals from Black, Latinx communities also lack confidence in the vaccine more than whites do. So physicians are going to play a really critical role in dispelling myths about the vaccine. And so that's what I wanted to share. There are a few key questions that we need to really be prepared to answer. And also in our research, we found that people are expecting us to have an answer at the tip of our tongue. So that half second of hesitation that you might have if somebody asks you if the vaccine is safe could kill their confidence in the vaccine. So when somebody says, is it safe? You need to say yes, because. If somebody says, can this mess with my DNA? You need to say no, because. If somebody asks you, will this give me COVID? You need to say no, because. So you really need to have an answer at the tip of your tongue, because that half second of hesitation, people are picking up on that, and that's leading to confidence issues. So hopefully by the end of this, you're going to feel confident in answering those questions. Before I kind of jump in, can you still see my slides? Okay, great. Before I jump in on the vaccine candidates, I just wanted to show a picture of SARS-CoV-2, which causes COVID-19, and just reflect on the fact that the target of most of the vaccines that are currently in phase 3 clinical trials is the small spike protein on the outer shell of the virus. It's the spike proteins that bind the ACE receptors in your body. They enter your cells, they hijack your cell's machinery, they replicate and go on to injure your body in very, very different ways. So early on in the pandemic, scientists decided that these spike proteins are going to be the target of most of the leading vaccine candidates. And we didn't know until phase 3 clinical trials were published that that would actually work at preventing disease. So that was a huge bet that people made. And there's good animal data that says it was a good bet, but you never know until that phase 3 clinical trial is completed whether or not that was the right bet. So when people hear vaccine, when the lay public hears vaccine, they immediately think that they're getting some sort of inactivated whole virus or like an attenuated form of the virus, because that's really the classic vaccine approach that was perfected in the era of polio. That's what our grandparents think that we're getting with these COVID vaccines. And what's really happening is that companies are using innovative ways of vaccinating, and this mRNA approach is a really exciting one. And the idea is that you teach the body to recognize the spike protein without actually exposing you to any other components of COVID-19 or of SARS-CoV-2. So there's no risk to immunocompromised people, for example, of getting sick from the vaccine. So the approach that Pfizer and Moderna are taking is this mRNA approach. And what the vaccine is actually very simple. It's a tiny shard of mRNA that encodes for the spike protein, and then it's wrapped in nanoparticles of lipid. It's kept at ultra low temperatures, and then it's delivered in the form of an injection. And once it's injected, you can see that the mRNA enters your cells, and then the ribosomes decode the mRNA, and they spit out little tiny spike proteins, fragments, and then also whole proteins. And the spike proteins, they're foreign to your body because they don't have your own cell signatures on them. They don't have HLA markers or other things that make your body recognize your own proteins. So remember, it's just like any other virus, like HIV is a perfect example. HIV hijacks your cell machinery and it replicates, and then it spits itself out. The coronavirus does that. It hijacks your cell machinery and it spits itself out. So these are all foreign objects. It's not, it's recognized as foreign object, and your immune system kind of takes it from there. So then the question is, how effective are these vaccines? And if you've read the New England Journal study that just came out on Thursday, the vaccines work really, really well. Pfizer's clinical trial enrolled 44,000 people, and they randomized them on a 1-to-1 basis to vaccine or placebo. And you can see the red line shows COVID-19 infections in the placebo group, and the blue line shows it in the vaccine arm. So the vaccine group separates at about 10 days after the first injection. So there's actually a little bit of efficacy that you get even after your first dose. And the trial wasn't powered to adequately assess first dose efficacy, but it calculated it to be at about 55% effective about 10 days after the first dose, which is really remarkable because when the FDA published their guidance on what they wanted manufacturers to have for a COVID vaccine, they wanted to only look at applications that had vaccines that were 50% effective. So even after that first dose, they kind of cleared that hurdle that FDA had set for them. And then you also consider the fact that the flu vaccine is only about 40 to 60% effective. So that's just with the first dose. And by the time you get your second dose, you're close to 90% effective. And then 7 days after that second dose, you're 95% effective. So also of note, most of the severe cases of COVID occurred in the placebo arm, so in that red arm. It's too small to see, but there are little S's on this chart that indicate the severe COVID cases, almost all of which happened in the placebo arm. And that's really important as well, because there's something that vaccine manufacturers look for, and it's called vaccine-mediated viral enhancement, where you get a worse infection because you've been exposed to something. And this happens with certain viruses. It's not entirely clear why it happens, but it is something that vaccine makers power their studies to detect. And it was not detected in this study. And just intuitively speaking, if you look at the data, if this vaccine was kind of leading to viral enhancement, then you would see a lot of severe COVID cases in the placebo, in the vaccine arm, which you do not see in this study. The side effects are all in the journal report. You can pull them up and look at them. As with all randomized blinded trials, I think it's always interesting to look at the side effects in the placebo arm. There are a fair number of side effects that people that just got saline felt. A lot of people had fever in the placebo arm, or fatigue, diarrhea, among other things. So there are going to be side effects, but it's important to remember too that people who got placebo felt side effects as well. So Moderna's data isn't yet published, but they use a very similar approach and they've reported similar efficacy. And I'm in the Moderna trial, so I'm really anxious to know if I got vaccine or placebo. And the plan for clinical trial participants like myself, and I know this because I just called them, like begging to know what the deal is because I'm so anxious to get the vaccine myself. But they basically anticipate an authorization on Friday, and then they're going to bring us all in to get crossover if we got placebo as opposed to getting vaccine. So I'm hoping to get vaccinated through the clinical trial next week. So you guys are going to beat me, and I have serious FOMO over that. So these are the various approaches. Moderna and Pfizer get a ton of attention for their mRNA vaccine, but there are other approaches being looked at. And the key thing to know about mRNA vaccines, even though this is the first approval, or authorization of an mRNA vaccine, there actually are dozens of mRNA vaccines being looked at for other conditions like CMV, Zika, Ebola, cancers. So mRNA is not a new technology, it's just a new authorization. The mRNA has a very short half-life. It degrades in about a day. And that's why it's so sensitive and why it has to be wrapped in that lipid nanoparticle and then frozen at these ultra cold temperatures to keep it from going bad. Because once it's in your body, it's going to go away in about a day. And the proteins that it code for, they're filtered out by your liver in about the same amount of time. So this is not a drug or a vaccine that goes into your body and stays forever. It doesn't change your DNA. It doesn't go to your nucleus. So that's a really important thing for folks to recognize. But there are other approaches being looked at. Some are using kind of more experienced platforms, like J&J is using their AdVac platform to study an adenovirus vector vaccine. AstraZeneca partnered with Oxford. There's obviously Sputnik 5, which is the Russian vaccine, and then the Chinese vaccine as well. So these are all different approaches using a variety of different technologies, but mRNA is clearly the leading edge. So typically, the vaccine process takes many, many years, and everyone kind of wonders why it happened so fast here. And that in part is because mRNA vaccines have been being studied for the last decade. There are 12 mRNA vaccines that are being looked at for those diseases that I mentioned. And we actually just benefited from that. There was a lot of background research into coronaviruses as well. So typically the phases of clinical trials, the preclinical testing is usually when you find the target, you do the work all in the lab. Phase 1 and phase 2, they started in April of this year, and they're still going on now. So that's when the small number of people got the injections, and their immune response was just measured by taking their blood to see what their antibody levels were. And then the phase 3 clinical trials, those are the largest ones that have at least 30,000 participants. And the goal of those phase 3 trials is not to look for antibody response, it's to look at disease prevention, it's to look at efficacy. So Pfizer's clinical trial had 44,000 participants, Moderna's has 30. Johnson & Johnson has 40,000 in their clinical trial of an adenovirus vector vaccine. And one of the reasons that we got to an answer so quickly is because the virus is just everywhere. I mean, it's so rampant right now in the US that you could detect all of these cases. People were exposed to it. So there's an mRNA MERS vaccine, for example, that is still in clinical trials, but there's not enough MERS in the world to be able to evaluate its efficacy. So that's the key difference. You know, you could come to an answer when there's a raging pandemic and there's so much disease going on, in particular in the US. So it's important to note, even though mRNA vaccines have not been approved or authorized in the past, they've been in development for a long time. This phase 3 trial, the FDA required 2 months of post-injection safety data from the second shot. So that's really like 3 months of data for people that have been enrolled, you know, from first shot, second shot, 2 months after the second shot. That's 44,000 shots. Times 2, 88,000 shots. It's a lot of data. They say if you stacked all of the data from the clinical trials, sheet by sheet by sheet, it would be about as tall as the Sears Tower. So 150 people at the FDA worked on the analysis of all of this data. They came up with an answer in a matter of weeks. They worked around the clock. A lot of our friends in the area, I think some folks in our group work at the FDA. It's also important to know that the phase 1 and 2 clinical trials are still ongoing. They started in the spring. So those people that got the shots back in April, they're still in the trials and their data is kind of accumulating over time. And there are also a variety of post-authorization safety databases that the government maintains, like the CDC, Department of Defense, FDA. They're all going to look at post-authorization safety data. And then it's just a really good thing to remember that we are just not the best judges of our own risk-taking behavior. So we're all afraid of the unknown. I totally get that. But you know, when you ask somebody like, what's the most dangerous part of a vaccine? What's the most dangerous part about getting vaccinated? Anybody know? The answer is driving in your car to get it. That is by far and away the most dangerous part about getting vaccinated. We take on much more risk by driving to get the vaccine than we do by actually getting it. And as emergency physicians, driving to work, to the ER, to take care of patients that have COVID, that is far more risky than getting a vaccine that's gone through this level of review. So the data that we have is really, really stellar. The safety profile is largely known. Are there risks? Absolutely. There's risks with everything that we do, including going to work every day. But you know, I feel very confident in the data. So I'll just kind of conclude and wrap up with the key questions that I think we should all be prepared to answer. The first one is the vaccine going to give me COVID? And the answer is no, because this mRNA only encodes for the tiny spike protein on the outside of the virus. It's not a whole virus. The second question is the vaccine going to mess with my DNA? And the answer is no. The mRNA is transcribed by your ribosomes. It doesn't go into your nucleus. And then finally, is the vaccine safe? And the answer is yes. It is, because there's significant data backing it up. It went through as thorough of a review as other vaccines, and if not, a more significant vetting than other vaccines on the market. Are there still questions? Absolutely. But we're taking a lot of risk by going to work and caring for COVID patients. And so, you know, I feel really confident and I'm excited to get vaccinated if I haven't already. So with that, I can, I guess, pause and I think maybe take some questions.
Yep, that's great. Mike, thanks so much for that presentation. And just a reminder to everyone that's participating, I think we have over 70 strong thus far. Please feel free to include any questions in the chat, either privately or to everyone, and we'll make sure that we cover those questions through the course of discussion and conversation over the next several minutes. Just wanted to turn it over to Matt Wilson for any additional thoughts. And I know Matt has spent a lot of time looking at vaccines and the literature and just opening it up, starting with Matt, and then we'll ask all of our panelists to provide additional insights as well.
Thanks, JD. I couldn't have possibly more to offer than that expertise from Mike. That was outstanding. I also know from meetings this morning that Kate has a lot to say about MedStar's approach and the CDC recommendation. So I'll pass on my turn to her.
Sure. Thanks, Matt. And so just over the weekend, the CDC did release updated information. They put up a number of new sites, which, John, we can get sent out for sure. But a bunch of new FAQ sites that I think are really good. And they're actually having an open call for providers at 1 o'clock today. They did a webinar yesterday that we thought was really excellent. So if anybody wants information for that, you can just look on the CDC website. It's the COCA webinar. It's at 1 o'clock today. So kind of some of the basics that got covered over the weekend that were kind of a little bit more up in the air last week, just to share with all of you, is just, so number one, there was more clarification around the allergy piece, around people with severe allergic reactions. And they've determined that it's only folks with severe allergic reactions to injectable medications that need to hold off on the vaccine for now. So folks that have allergies to foods or other, insects, those types of things, they can have vaccination. And all of our vaccine centers at MedStar are going to have EpiPens and, a plan for emergency response and all that. So you can just know that if anybody asks you that. The next thing was about pregnancy and breastfeeding. And so last week, ACOG and the Society for Maternal and Fetal Medicine both said that they think that particularly healthcare workers that are pregnant and breastfeeding should be allowed to have the vaccine. And over the weekend, the CDC concurred with that, basically saying, it's a personal decision, but the mRNA vaccine, there's no reason to think that there would be an increased risk. And we know that pregnant women are at increased risk from severe COVID-19. So we should be allowing that to happen, and so make that decision personal for folks. And then also, I think Mike, again, Mike, thanks so much for that presentation. It was really good. And you mentioned the immunocompromised. They said the same from the CDC over the weekend. And finally, the last thing I'll just mention is if you've had COVID-19, should you get the vaccine? And they're saying that indeed you should get the vaccine, but we do know that there's some immunity in those first 90 days. So if you can, because our supplies are limited here at the very start, if you've had COVID in the last 3 months, you can wait and allow someone who doesn't have immunity to have that vaccination and then get the vaccine after that. But there's no reason not to get it if you've had COVID. So I think those are the big updates. Yeah. Matt, I don't know if I forgot anything else that you wanted me to mention.
Well, I might just throw in and I kind of mentioned this on the allergy piece. I think that's a really important thing that we are still trying to understand. Nobody really knows, and there is an investigation going on. The FDA is working with the UK equivalent to understand what happened there. But the mRNA vaccine is pretty simple. My understanding is there's not a lot of additives like, some of the other platforms use egg, for example, and this is really just mRNA wrapped in 4 lipid nanoparticles. So there's some thought that it could be polyethylene glycol, which is used to kind of hold the lipids together. That's not definitive, but there's not a ton in there. So there's an investigation going on, and hopefully we'll kind of come to some sort of conclusion here in the next few days with a little bit more firm guidance.
I think that'll be good. And hopefully we can let more people have it. We can make that less, it's really conservative now. I think they're trying to be conservative. So hopefully they can expand that.
Great. Several questions are coming in. The first of which is, how long is the vaccine effective for? And so Mike, if you want to answer that one based on the snapshot of data that we have thus far.
Yeah, nobody knows because we don't have enough long-term data. That's actually why they want folks to stay in the clinical trials for the full 2 years, so we can kind of know how durable of an immune response. We do know that the immune response is, quite strong to the vaccine. There's really good antibody titers in folks that get it. So that's why they're going to keep the trials going to kind of know if you need a booster shot or not. But we know that the vaccine does elicit a really strong immune response. Is there a possibility that you could need a booster? Absolutely. We just don't know yet, and we'll have more information at the end of that 2-year period.
Great. An additional question: if you are considered immune for 90 days or thereabouts after infection with COVID-19, presumably secondary to the development of antibodies, why do we expect the vaccine to provide a longer period of immunity, a longer tail beyond that 90-day period?
Well, I don't think we really know how long you're immune to it. That 90-day period is a little bit, it's not, based on super firm science. I think that there's some perception that if you had mild illness, you could have shorter immunity. If you've had severe illness, you would have longer immunity. And the mRNA vaccines, the data out so far kind of indicates you're getting a really good immune response to it, equivalent to a severe case of infection. So I think the concern is that people that might have had mild or asymptomatic COVID aren't actually mounting a really good immune response, and so aren't adequately protected against it. So I think that 90-day period is kind of what the CDC came up with, but we don't really yet know.
Another question. Those who are vaccinated, does anyone know whether they can still transmit the virus, even though they don't become clinically symptomatic themselves?
Yeah, unfortunately, the trial, the Pfizer trial wasn't designed to really detect that. In order to know if you're not able to spread it, they would need to be doing kind of real-time testing on an almost daily basis of the clinical trial participants. And another reason that the trial was completed so quickly is, in part because of the significant disease burden in the US. But the second reason is because it was all very digital. As a participant, I can speak to that. I mean, I only went to Maryland twice. I went to get my shot, in August. I went in September, but every other time it was all on a phone app that I just, did symptom checker. I talked on the phone to the coordinator. They did it for this reason, to try and speed the process along. But because of that, there wasn't, we didn't do like daily PCR or nasal swabs of folks to be able to determine if there's kind of asymptomatic transmission going on. I will say the AstraZeneca Oxford study did have a subgroup where they looked at that, and they found that their vaccine, even though their efficacy rates are lower than the Pfizer vaccine, their vaccine did diminish, asymptomatic spreading. So they tried to answer that question. I think there are going to be studies of the Pfizer vaccine in the coming months to try to answer that.
Great. Another question that came in is, we obviously don't have any long-term data available as of yet, but are there any theoretical long-term risks of the vaccine?
Well, we don't have any long-term data on this particular mRNA vaccine, but we do have long-term data on other mRNA vaccines. So I mentioned mRNA is being used to study things like CMV, Zika, also MERS. There was an mRNA MERS vaccine. So there are people that have had mRNA vaccines, 10 years ago. They're also in use for diseases like cancer, as therapeutic option as opposed to preventative. So I'm not aware of any long-term safety signals from folks that have been getting mRNA vaccines for other conditions. There's, it's thought of as a relatively safe modality because it's got a really short half-life and it's just in your body for a couple of days. And then the spike proteins that it's spitting out are also really in your system for not very long.
Additional questions for women considering becoming pregnant. Is there any concern that the vaccine could cause problems?
Not that I'm aware of. I mean, I would definitely talk to your, talk about your individual situation with your doctor, but not that I'm aware of. And I think the fact that the CDC kind of leaned in on pregnant women, apparently my understanding is it's not thought to cross the placenta. Kate, I don't know if you want to add anything there.
Yeah, and I think basically, and you said it too, Mike, the way that this works, I mean, mRNA, that doesn't live, it doesn't stay around very long. It's basically just about mounting that response. So there's no reason to think that there would be any lasting effect, but agree, I think it's something to talk specifics with your provider, but we haven't seen anything directly that would be concerning for that.
And John, if I can just add, ACOG and the Maternal Fetal Medicine Societies have both said that pregnant women should get it. We checked with Tamika Agusti from a service line standpoint. MedStar Health encourages it. Our stance is that people should check with their obstetrician, and we're not blanketly saying that we would advise it. We want them to talk to their obstetrician. But the idea is that pregnant women are at higher risk if they get COVID. So from a risk-benefit standpoint, it's suggested. The only caution that was given was early pregnancy, there's an increased perceived risk of fever. So it's more important to take Tylenol if you have the side effect. And I just want to make one comment about the earlier comment, Mike. Mike, first of all, that was an absolutely outstanding presentation. One of the best presentations I've seen this year on anything. So thank you. And one point that I think is really important to emphasize is the reason this is an EUA is not because it has less people in the trial than a normal vaccine trial. It actually has more than many. It's the follow-up time, but essentially all bad side effects happen within 8 weeks. And so they followed it out to 2. So we can be very comfortable about the terrible adverse reactions. But to Mike's point, we don't know the long-term efficacy because we don't have the 6-month and further out follow-up yet.
Yeah, that's a good point because other countries are granting full approvals. Just in the US law, the law that governs the FDA requires 2 years of data before the FDA can grant a true approval. So we call it an authorization because the pandemic preparedness laws allow the FDA to grant authorizations for drugs under an emergency use. So it's a little technical, but the UK, for example, granted a full approval to the Pfizer vaccine. It's just a different structure, regulatory structure.
And when you're talking to people that are worried about whether there's a bias from the government, there was reportedly heavy pressure on the CDC to shorten that 8-week requirement that they have, and they held to it, and they said, nope, 8 weeks, we're not going to change that. 8 weeks is our minimum for safety. So it was reassuring to hear that.
Great. Another question came into the chat. I think it would be helpful, Terry and Kate, if you could field this one. What will MedStar's policy be when getting the vaccine? Should we not go to work assuming it could be COVID, bad timing, or just assume it's side effects from the vaccine itself?
It's a really good question. It's a huge one for sure. And we're going to be coming out with some written guidance on this, but I'll give you the preview, which is basically, we know that there's obviously symptoms in the Venn diagram that overlap between your post-vaccination symptoms and your COVID symptoms, right? So myalgias, fatigue, some general headache, those kinds of general symptoms we definitely can be post-vaccination. But then for those symptoms, excluding fever over 100, if you feel well enough to work in the day or two post-vaccination, and also those symptoms should go away in a day or two. They shouldn't usually last longer than 2 days in the trials. So if it's within the first day or two and it's those symptoms that overlap, then you can go to work if you feel well enough to do so. We are saying that if it's possible for you to schedule the vaccine before you have a day or two off, it's probably advisable, just because you may not feel so great. And also with the second dose, the post-vaccination symptoms were worse. So just to keep that in mind when you have your second dose, you may want to have the next day or two off just to rest. But if you don't have a fever and you feel well enough to go to work, you can. Now, if you're experiencing symptoms that are not typical of post-vaccination, like loss of taste and smell, shortness of breath, cough, those types of symptoms that we don't expect to see after the vaccination, then you need to be concerned about COVID. And that's when you should be doing all the normal things like calling out health, getting a swab, staying home, and all of that.
Great. Thanks so much, Kate. And another corollary that I think it's important to reemphasize and be interested in your take on this and the position on this. But we know that vaccines are great in many ways, but they're not 100%. So what should we be anticipating in terms of PPE following more widespread vaccination throughout our health system and throughout other health systems as well?
Yeah, that's a really good question. So for now, you should expect nothing to change. So we know 95% efficacy. That means there's a very small percentage of people who could still be sick. And then as Mike said, we still don't know if there's going to be transmissibility, asymptomatic transmission that's possible. So particularly as we have smaller percentage of the population that have been vaccinated, we're sticking with the same plans for PPE going forward. Now, as we get more and more folks in the community, and particularly if we can get good uptake, 75, 80, 85% uptake within the community into the springtime, that very well and hopefully will be able to change. But in the next couple of months, I don't see that we will be changing that dramatically at all.
Great. And then what about vaccine availability? A question, the ED will have access in the first wave to the Pfizer vaccine, but what about clinicians who opt not to take it up front? What will availability look like? Is it a golden window, and if you miss that window, or continued availability moving forth?
Yeah, so we're expecting, and again, this is 2020, this is COVID, so everything I say now could be different in 2 hours, but we have pretty good reason to believe that we're going to be seeing consistent supply of vaccine over the next few weeks. We do not think it's going to be like the delivery this week and then that's it for 3 months. We have no reason to think that. We're fully expecting that we're going to be seeing repeat deliveries over the next few weeks and in 2 months, and that will add Moderna as it becomes available. Now, there may be some things in terms of the distribution of which vaccines are offered where. For instance, the Pfizer we know has that ultra cold storage element, so that's being probably going to remain in our hospital settings where we have the facilities to maintain that ultra cold storage. Moderna is not going to have that ultra cold storage need, so we may be able to do that in some other more ambulatory locations. Those sorts of things that may drive some of those offerings, but certainly if you hold off on getting it now, you most certainly will be able to get it when you decide to get it. And we fully expect that the availability is only going to increase.
Great. Thanks so much, Kate. And tossing it back to Mike for a couple of additional questions here. Is there a concern that the vaccine will be less effective based on viral mutations? And we all know that all viruses have a penchant for changing themselves and becoming that chameleon, so to speak. What about changes to the spike protein? If mutations were to occur, how that would impact the vaccination?
Yeah, so it depends on how significant of a mutation it is. And we haven't seen so much drift yet in this COVID strain, or in this SARS-CoV-2 that we've had, a lot of concern that there's such significant mutation that would impact the vaccine. That said, it's something we're going to have to be monitoring for to determine if there is kind of a variant that would make it difficult to vaccinate against. The good thing, though, is that with these mRNA platforms, now that we have kind of proof of concept and that they work, the manufacturing is relatively, the ability to design a vaccine is actually relatively quick. So back in January, when the Chinese released the sequence of SARS-CoV-2, they actually designed the Moderna vaccine in 3 days. And then the Pfizer vaccine was in clinical trials within a couple of months. So these platforms are really built for task. And it's just kind of incredible that it was the right moment in time. Don't want to say we were lucky, because nothing about this makes us lucky. This is all kind of an awful thing, but we are glad that this technology was kind of right for the moment. And I think it will be easy to deploy should a mutation come about, and an adjustment could be made.
So Mike, an additional question is, there's been in some reports that the vaccine, as it's supposed to, stimulates an immune response, but what about that hyper robust immune response? And any concern regarding over response and complications later down the road?
Yeah, so that's something that the clinical trials are designed to monitor for, this kind of the vaccine-mediated viral enhancement. That actually, the theory behind it actually arises from viruses themselves, where you're exposed to a virus once, you kind of have mild illness, and then the second time you're exposed to it, you have a much worse, because your antibodies actually facilitate the virus entering your cells and replicating. So it's something that the clinical trials are designed to monitor for. And, there's actually a section in the New England Journal article that talks about it, and they have a very high kind of threshold for detecting any type of this enhancement. And again, the data is pretty complicated and it's very stats heavy, but even just looking at the Pfizer data, the fact that, there were 160 people that got COVID, basically almost all of them were in the placebo arm. And then almost every severe case, including one death, happened in the placebo arm. If you had this kind of vaccine mediated viral enhancement, you'd be seeing, severe COVID cases in the vaccine arm as opposed to in the placebo arm. And I'm sorry if I got that backwards when I said it, but 160 people that got placebo, got COVID as opposed to people that got vaccine. So if you were worried about the vaccine making people sick, then you would see it in the clinical trial. It's designed to monitor and test for that.
And turning it back to Kate, vaccination impact on policies and procedures, such as the need for quarantine when you have a positive COVID positive family member or household contact. It might be things that are emerging and adapting and evolving over time, but any initial forecasts on how it might impact some of these policies?
That's a really good question too. I think, again, I don't foresee any significant change in the immediate future until we get a good chunk of the population that's vaccinated. And then the household quarantine, I think, because there's still, we're not 100, it's not 100%. I don't see a likely change in that coming down the pike, but I think that'll kind of remain to be seen in the next few weeks as things emerge. And as we get more advice also from the departments of health, we're seeing things from the CDC and all of our jurisdiction departments of health come out literally like every few hours in the last few days. So we may get more guidance from them on that in the coming weeks as well.
Great, thanks, Kate. And Mike, turning it back to you, efficacy endpoints for trial participants who only received one dose. We all know that compliance can be an issue, specifically with that second dose. And so any comments regarding participants with one dose, if there are any, if there is information that can be shared in that regard?
Yeah, I think there were a few, but for the most part, the trials actually didn't have a whole lot kind of lost between the first and second shot, and that is going to be important. I think Operation Warp Speed is providing little paper cards to give to the patients so that you know when you need to go back. And then I don't know if MedStar is invested, but a lot of health systems that are administering have developed some kind of apps and push technology to phones to make sure people know exactly when they need to go back. There is wiggle room in when you can give the second shot. You know, it's not super critical. You give it at day 21 and 28. And there is efficacy that you get from the first shot. It wasn't the trial, the Pfizer trial that was published in the New England Journal wasn't powered to detect or assess what the efficacy is, but they did report the number. So kind of take that for what it's worth. They reported a 55% efficacy about a week after that first shot, a week to 10 days after the first shot. So you do get protection from it. And actually the incoming director of the CDC wrote an interesting article about this. She's the chair of infectious disease at Brigham. And she basically argues, and some other kind of public health folks argue, that you know, we would just get benefit from vaccinating as many people right now with one shot. You know, it's better to vaccinate everybody with a 50% effective vaccine than to vaccinate a small number of people with 100% effective vaccine, because you'll get, you know, better suppression of virus. That's not what the FDA is saying. That's not what Pfizer is saying. So I want to be careful and just kind of prevent that as an outside perspective. That there is kind of, you know, there are people out there that are saying get as many shots in arm as possible today as you absolutely can. But I think that the government has held back supply in hopes of really staggering the doses so people don't miss that second shot.
Great, thanks, Mike. And Kate, an additional question for you. I know you have to jump off shortly, but I think this is a really important question regarding strongly encouraged, strongly recommended versus mandatory, and sort of the decision-making behind that and the rationale why in our health system it is strongly encouraged but not mandatory.
Yeah, and it's pretty straightforward. It's because the vaccine's under an EUA. And it's really hard to mandate something that's under an EUA. And we, even though it's under an EUA for all the reasons you've heard, I think we all feel really strongly and really good about the data and about the fact that it's safe, and it is really the thing that is going to get us out of this pandemic. But when something's under an EUA, it's hard as an employer to mandate that folks do that. So while it's under EUA, we're strongly encouraging, and we're trying to give as many people as we can the tools to understand what we know about the data. And I'm going to be stealing some of Mike's stuff to continue to do that. But because we really want people to understand in terms of safe and efficacious. So, but for now, that's the reason there, John.
Great. Thanks so much. Need it. If there are additional questions, and if we could just ask everyone to kindly place yourself on mute. We're getting some background there. We're going to from vaccine, and we're going to talk about the foundations of the ED evaluation and critical care. But as additional questions arise, please feel free to continue to place them in the chat, and we'll do our best to cycle back. And thanks so much, Mike, for an exceptional presentation, and Kate, and to others for contributing to the discussion as well. Really, really great discussion. So why don't we go ahead and transition? We're going to transition to Carrie to talk a little bit about the foundations of ED evaluation, labs, when to get a CT, when to admit, monoclonal antibodies, a lot of stuff that has changed in the last several months. So a tall order. I'll turn it over to you, Carrie.
Okay. I'll try to answer some of the questions that I've been getting from everyone, as opposed to getting really deep into any particular lab value. But I know there are some themes that tend to crop up. So one of the things that's become very clear to me is sort of when someone can go home versus when they're really sick. I think that like middle category is where people have a lot of questions. And so most of the big systems that we've looked at, including the Brigham, Boston, Columbia, NYU, the World Health Organization, really draw a level when the oxygen saturation drops below 93%. And the way we set it up, when you look at our COVID guidelines, you can see that 94% is what we use. So if you have a patient that's satting above 94% and they don't have increased work of breathing, in terms of their respiratory rate is not greater than 30, they look, relatively okay. They probably have some symptoms, fevers, headaches, those sorts of things. they can usually be safely discharged home. In those patients, there's a nuance since the summer with the monoclonal antibody. And so I think it's a good time to talk about kind of the different treatments that we have available. And so the monoclonal antibody, then there's remdesivir, then there's Decadron. So I'll leave the conversation about steroids to Rory, because that's on the latter end usually. And so when you're talking about a monoclonal antibody, right now we have it restricted to patients that are high risk. And so in general, the older, greater than 65, BMI greater than 30, patients with CKD, diabetes, coronary disease if they're older, COPD if they're older. But in general, in the patients that are older than 12, you can give it and start to look at risk factors. And so what is the monoclonal antibody? So the monoclonal antibody was derived by looking at the human serum of patients who had been infected early in the pandemic in March. And what they did was they developed a antibody to the viral spike protein. So if you think of the disease, you want to catch people early if you're going to give them the monoclonal antibody, because it's trying to attach to the spike protein and disable the virus from infecting your cells. Right. And so that's why you want to catch them at the beginning of the disease. If they're already requiring oxygen and they need to be hospitalized, they're probably too far along for that antibody to have much effect, because the cells in your body have already been infected. So when I think of monoclonal antibody, I think that perhaps some of those patients that we were discharging in the spring, where we didn't have any monoclonal antibody, now maybe that they're getting it, they might not be bouncing back as much as they were. That's my hope. And I know that we've given it a fair amount throughout our system, and we haven't seen any of the scary allergic reactions that we've heard about, but we're continuing to monitor for that. So the second drug that people think about is remdesivir. Remdesivir has been around for a long time. It was initially, it's called Veklury, that's the trade name, and it was made in order to try to combat hepatitis initially, but it didn't work. And then it was tried against Ebola and it didn't work. And so, I was already a little bit skeptical about the medication, to be totally honest, but essentially it blocks enzymes used in viral replication. So, this tries to stop the virus from replicating itself. So that's kind of in that second category of patients. They're sick, they're getting sicker, they might be requiring more oxygen. So typically they're in the hospital. There have been multiple studies done on the medication, whether it's caused improvement. There was one big Chinese study that showed no improvement. But then there was another study that came out that showed that in the patients on the 5-day arm of the medication, it actually did show a decrease in the amount of time that they were critically ill, and a decrease in the hospitalization time by I think it was about 4 days. And so there really haven't been any major side effects that I've read about of getting the medication. And so I think it's worthy of consideration. There's still a shortage of the medication, although we have a decent supply of it. And so there are criteria for deciding who to get it on. And essentially patients that are already made it to that ventilator phase of the disease don't benefit as much from that medication. And so those are the medications that we have out there. And so then you kind of run into that, what patients can I send home? What patients do I need to get admitted? And how do I figure that out? And so it is the thought that in most cases, the decision to send a patient home can often be made on looking at the patient, assessing their vital signs, their respiratory rate, and their oxygen saturation. There has been some utility found in using the ambulatory saturation. I think the best study I've seen has been at NYU on that. Essentially, it shows that patients that have a resting saturation, that's okay, but then their ambulatory saturation falls to a significant level. Most of us think below 92 or 90%, depending on which study you look at. Those patients do tend to do worse. And so I think it is important, and it can help you to find patients that you may think look okay initially. And so then what else do you need to do in the ED? And so there's a question about imaging and labs. So if you have a patient that you're not sure if you're on the fence, the chest x-ray might help you. So if the patient has risk factors, or if they kind of look okay, but maybe not, you can look at the chest x-ray. And if they have greater than 50% infiltrates in their lungs, they tend to do worse. So the chest x-ray might help you there. In pediatric patients, the respiratory rate's not as helpful. In general, you're looking for hypoxia. In pregnant patients, you may set your bar slightly higher because of the physics of chemistry. Sometimes if a patient falls below 95%, you might think about bringing them in as opposed to the 94% cutoff. So that's the chest x-ray. Then the question is, there's a lot of questions about troponin, D-dimer, procalcitonin, CRP, CAT scan. And I'll try to just answer those as shortly as I can. Who should I get a troponin in? Most people think that if you're thinking that the patient is having, an MI type event, you should continue along the pathway that you normally use. So if you think the patient is having an MI, you use the EKG as your screen, right? And then you decide, do I need to go down the ACS pathway? If you're going down the pathway, then that's when you use the troponin. The reason I say that is because troponin has been shown to be elevated in about 1/3 of patients with COVID. So it's 27.8% in one study. And a lot of that is because the virus itself can cause myocardial cell rupture, because it essentially causes the cells to engorge and then explode. And so in patients with CHF, CAD, you tend to see it more. There is the possibility of causing ischemia, though, because those patients, they have to work harder, right? And so if they already have blockages underlying, that could then lead them down to the MI pathway. There is a component of viral myocarditis as well that's been seen. But I would say start with the EKG, then decide if you need the troponin. I'll quickly talk about procalcitonin. It's a questionable indicator of disease severity, but it hasn't been tracked on a level that shows that it's easy to correlate. CRP as well, it shows inflammation, but it's, I don't know that it's that helpful in the ER population. Then we get down to D-dimer. I think D-dimer, there's been a lot of research in D-dimer, and essentially, if you look on Elsevier, I think you can see kind of the latest study. There's a good study. It's the association between D-dimer level and mortality in patients with COVID. And there's a systematic review that just came out in September. It's, participants from France, Canada, also the Brigham and Mass General. And so in that study, essentially, it does show that there is a correlation between elevated D-dimer level and disease severity. The problem is that a lot of these studies were done on admitted patients. These are not done on patients that we're sending home from the ED, right? They're not on those patients that look good, right? So that's one confounder. The second confounder is that early on in COVID, we started seeing huge clots. I remember going to meetings, and I think Dr. Trenkin brought a photo of a clot that she saw. And so I think we all got concerned that we were seeing a lot of clotting. And so the inpatient population, we started on a anti-thrombotic protocol. Most hospitals across the country and the world did that. And so we don't know if that's affecting the levels of clotting that we're seeing. We hope it is. We hope we're seeing less clotting because we're preventing it. And then the second problem is that when we are seeing clotting and increased worsening in patients, a lot of that is not based on the initial D-dimer value. A lot of that is based on the peak D-dimer value that you're seeing in patients. So the trending of the D-dimer is what is helpful. And then a lot of the studies done on D-dimer sort of had a design that caused problems. They picked an arbitrary level, such as 1 or 2. And so it's hard to put those all together and give it meaning. And there's at least five different D-dimer systems out there that are based on different values. So it's hard to just look at it and say yes. What we do know is that it seems that the D-dimer levels are elevated more than usual in COVID patients. And so, it may be that our cutoff level is too low, but I can't say for sure. So I would say if you have a patient that normally meets your concern level for getting, you know, a PE workup. Sometimes the D-dimer can be helpful because if it does come back low, you may not need to get a CAT scan in those patients. And it can be helpful if you're admitting the patient so that they can trend the level. In terms of the CT, I don't think that you should use the CT to look for the severity of the pneumonia from an ED perspective. I think with your chest x-ray and looking at the patient yourself, you have a good idea. I think that we should be limiting that to the patients we really think could have a clot problem. And then I think other than that, I think I answered like most of the questions I knew about, but I'm happy to answer any other questions that come up.
That's great. Thanks so much, Carrie. One question that came into the chat is regarding troponin and thoughts about troponin in identifying myocarditis and also in whom to get an echo and how it can help in that decision-making.
Yeah, sure. You know, I think troponin always can, you know, is elevated generally when you see an inflammation of the myocardium. I think you can still use your EKG and looking at the patient as your indicator that may be what's happening with the patient. However, you know, I would not dissuade you from doing an ED bedside echo if you're concerned, you know, about the patient's EF and that sort of thing. But in terms of looking at myocarditis, you may see some decreased pumping. You may see, you know, if they have pericarditis, you can see an effusion there. But I don't know, maybe Rory could answer this better. I don't know how much it would add in terms of the myocarditis picture.
Great. Thanks so much, Carrie. And why don't we use that as a transition point and a perfect segue into Rory and coverage of the critical care aspects, namely oxygen therapy, steroids, AC, anticoagulation, and also cardiac arrest. So Rory, I'll turn it over to you.
Sure. Thanks for having me. I'll just start with that question just so I don't forget about it later on. I think it speaks to the bigger point of figuring out when someone has COVID and when someone has a positive COVID test in another disease process. And COVID presents in many different forms. I think we're all aware of it now, but the COVID phenotype, which is the critical care one, is often very specific and very consistent. And upstairs, we often joke that we're taking care of the same patient over and over again since last March. But early on in the disease process is a relatively single organ problem of hypoxemia and respiratory distress. And so in the ED, when you see patients that don't kind of fit that phenotype and have other issues like hypotension or signs of shock, you often have to think, am I missing something else? And this is when I would go looking for that pulmonary embolism or putting an echo on to see why I'm dealing with shock or some other sorts, right? Because these patients can still get septic, they can still get MIs, and they can still get so on and so forth. So just having that phenotype in your mind, I think, is an important start, and knowing when to start looking for other stuff. As far as risk stratifying patients critically ill, I think Carrie went into a lot of good stuff. I honestly say that if all our labs broke today, I probably wouldn't have any issue with risk stratifying COVID patient. That's what's so nice about the disease. It's a very clinically oriented disease that you can simply look at a patient, make a call based on their work of breathing and their oxygen requirements. The data we have on risk stratifying them is pretty clear that hypoxia is bad, and any amount of hypoxemia is fairly bad. If you look at people that desaturate on ambulation alone, and we don't have perfect data on this, but the data we have shows so they have a normal sat at rest and they desaturate less than 94. Probably 1/3 of them go on to require high flow nasal cannula BiPAP or intubation. So not a little amount, right? That's a pretty high risk group. So we should have a lot of respect for hypoxemia in this disease. Even if they look well now, the question is, what are they going to look like in 12 hours? So once you've identified that group, you kind of, they might look good at this point. You've kind of identified the group who are critically ill and need some higher form of monitoring, and you have to decide what. I think patients that require higher levels of oxygen, so more than 10 liters or so, need an ICU care. And it's not because you need to go to an ICU to have 10 liters of oxygen. It's simply because these patients rapidly decompensate quickly and they need someone watching them. And once you're on high flow nasal cannula, again, the patients can look fairly well, but they are dependent on that oxygen. If it falls off them, they will decompensate almost instantly. And so having them in an ICU where they can be watched is so important. And so any kind of higher level of oxygen or rapid up titrate of oxygen needs at least an IMC or an ICU, or you've developed some kind of COVID floor, which allows for a higher level monitoring without a full ICU care, right? Because what they really need is high flow nasal cannula and someone to make sure it doesn't fall off. As far as therapeutics on these patients, again, I think it's fairly straightforward. My read on the literature is I kind of break it down into a couple things. You've got kind of modalities that work on viral load and our interaction with the virus itself, and then you've got modalities that work on the inflammatory process, right? So remdesivir, monoclonal antibodies, kind of working with our body's interaction with the virus. Steroids and toci are kind of working on the inflammatory system. Most of the data, from my perspective, the far most impressive therapeutic we have is steroids, right? It works far better than everything else we have. Toci, the recent New England trials basically shows it does nothing. And to me, that sort of made sense. I think we got on board with toci early on because we kept hearing about the cytochrome storm. And we kind of thought about toci because we use it to treat cytokine storm and CAR T therapy. And if you've ever treated someone with CAR T therapy, you know they look much different than COVID patients. And so it never made sense to kind of suppress one part of the immune system rather than dexamethasone, which is suppressing the whole immune system, right? And the data has shown that out, that dexamethasone is probably your most effective treatment. And so I would say anybody who comes in and you've identified as this phenotype of having lower lung or lower respiratory symptoms deserves to have dexamethasone, right? So anyone you're keeping in the hospital should get dexamethasone. And it, the study is 6 milligrams. But I think as far as all the data on steroids, we've never really found that any beneficial effects of steroids are class specific. And so you could probably give any kind of steroids and it worked just as well. There are other studies showing various other forms of steroids has similar efficacy. So, if you're getting into a shortage of dexamethasone, hydrocort or prednisone probably works just as well. And then as far as oxygen therapy goes, this is fairly easy. And I think we're all fairly good at this. I honestly, I can't remember the last COVID patient we've intubated in the emergency department at this point. Early in the disease process, they were all getting intubated instantly in the ED. And that was one, our discomfort with this hypoxemia, and two, our hesitancy to use non-invasive devices on them. And as we've grown far more comfortable to using high flow nasal cannula and BiPAP, we've become far less likely to intubate them early in the disease. A lot of them will go on to get intubated. If you look at the cohort that requires high flow nasal cannula, in most data sets, 50% of them or more go on to requiring intubation, but it's a long process, right? It's over 3, 4, 5 days that they decompensate to require intubation. So using that widely in the ED, I think is our probably best savior. I still like awake proning. Again, we don't have much data on that, and it sounds scary, but it's simply asking someone to turn over onto their belly. We have data that it certainly temporarily changes your O2 sat, but we have no real data or not whether it actually goes on to prevent intubation. But it's such a low resource tool that using it, I think, is still fairly viable.
Great. Thanks so much, Rory. And just sort of calling out the elephant in the room here, most emergency physicians are fairly risk averse. What we don't like is to send someone home and for them to come back within 3 days, 5 days, or whatever period of time and be swept into the ICU setting. That is a failure on our part. At least that's how it feels. So how do we synthesize all this information? And Carrie, I'll turn it back over to you. When looking at hypoxia and patients with they fall into two categories, clearly can go home, clearly need to be admitted, but then there's everyone else that sits in the middle. What are the best practices? Taking all this information, what should we do with these patients that fall in that gray zone?
Sure. I think for the patients that you can't just clearly look at, that's when you have to sort of go down and, what is their respiratory rate? How much work or breathing do they have? You can look at their chest X-ray to help you decide if they have pneumonia. I think that if a patient is having a saturation level that is dropping below 94%, whether they're ambulating or still, I think that is considered hypoxia based on the studies that you read. And so those patients, it's concerning that they'll get worse. So they're going to need a level of oxygen, most likely. They probably are in that stage where they're having an inflammatory reaction. So they'd benefit from those higher levels of care that are offered inpatient, which is why, if we're discharging patients from the ED in general, we're not prescribing steroids because they're not at the level that they're requiring that. And so I think, I think you need to heed the hypoxia, heed the respiratory rate, kind of make sure you're figuring that out. That being said, that because the trajectory of this disease, and the fact that we don't have monoclonal antibody just to give out to everyone that has it, it's kind of, in my mind, it's a little bit like heart failure. There are going to be patients who don't meet the criteria of being your most at-risk patients who are going to get worse. And that's why we have these vehicles that I think Ethan and Manish will speak about, where we can monitor patients. We have MedStar home monitoring, we have ready responders. That's where those things can come in handy to help us signal when patients are getting worse.
That's great.
Just a quick comment on that, because I do think that this ties back to the vaccine, and people are getting vaccinated, but we're going to still be dealing with this for very many months. And monoclonal antibodies are therapies that I would just get comfortable with, kind of like vaccine. I've just gotten really comfortable with it, and if I get COVID, I want it. Just personally, like I'm ready, kind of like the vaccine trial. Companies are ramping up production, and there are also going to be other companies coming to market. So while we're supply constrained now, I just want to make sure we're not like demand constrained either. And hopefully, the names are confusing, so patients are scared of them. We're not providers that often prescribe monoclonal antibodies, so we're a little nervous talking about them. They're generally very safe. I mean, there are people getting monoclonal antibodies every day for diseases like lupus and rheumatoid arthritis and cancer. And so we kind of know the reactions. I mean, we see the complications when they're in the infusion center and they need to come to the ER for us to treat them with Benadryl, basically. So it's just something to get familiar with, because there's a lot of pressure on the manufacturers to ramp up supply of monoclonal antibodies. We've seen our supply go up at Georgetown. I think I ask every week that I'm there. The first week we had 4, the next week we had 16, and then last week we had 28. So I think they're going to be more available. So it's just something to think about as the supply becomes less constrained.
Great point, Mike. And just turning it back to Rory, I just want to have one question covered, and then we'll go back to Manish and Ethan to talk about the COVID pilot project. And that question, Rory, from the chat is, should we be intubating sooner in the ED, since many of our, for instance, high flow patients are going to get intubated anyhow?
The short answer is no. The long answer is we don't know for sure. We're actually looking at this data at hospital center. You have two concerns. One, you intubate patients early, you're going to intubate more patients, right? Like if 50% of high flow patients are going to avoid intubation, then you're only going to have to intubate 50% of them, and you don't exactly know which ones you're going to have to intubate long-term in the emergency department. And so that's a problem. If you've ever managed a patient in COVID long-term on the vent, it's terrible. It's a terrible run. It's long. It requires a lot of sedation, and there's a lot of iatrogenic problems with it. And so you'd rather not. The disease process itself is one of a shrinking lung that gets smaller and smaller every day. And the smaller it gets, the more hemodynamic instability they have, the more organ failure they have. And so the ability to keep someone awake and alert and being able to maintain their own lung volumes is vitally important. The concern with waiting too long is just you've waited too long, and the intubation itself is incredibly harrowing, right? When you actually intubate these patients, when they're on high flow nasal cannula and a BiPAP over the top of that, and they're still satting at 88, they desaturate instantly, right? And so the intubation process can be fairly dangerous. So finding that sweet spot is important. I'll tell you, we haven't published our data yet, but looking at our data, it didn't seem that delayed intubations harmed anybody. So my thought would be no. It really is a terrible run on the ventilator that leads to a lot of iatrogenic issues. And so the longer you can avoid intubation on these patients, the better. And if you can imagine, this is in its worst form, a 2 to 3 week disease process. If you can cut down the amount of time you're spent on the ventilator, that's a win for the patient. Because the one thing I forgot to talk about on my last spiel was anticoagulation, because I think this is an important part, because often what we think about is COVID and macrothrombi, and obviously there is an increased risk of macrothrombi, especially in the critical population. Most studies that have looked at this, if you look at ICU patients in general who don't have COVID who are on prophylactic dosing anticoagulation, probably like 10 to 15% have some kind of VTE. In COVID populations, that's much higher. 40, 50%. Some studies have even shown 60 to 70%. So the thought is that these patients are not only at increased risk of macrothrombi, but they have this microthrombi phenomenon that might actually be part of the pathophysiology that we're seeing in the lung. And this might be related to the phenotype of this severe disease process. And so one of the recommendations we did at Hospital Center was to have this intermediate dose anticoagulation. So it's essentially double the dose of your prophylactic, with the thought that you're not only helping to prevent these macrothrombi, but actually therapeutically treating the microthrombi. The caveat here, there is really not much data on this at all. But just given the amount of difficulty we were having with macrothrombi, our CRT circuits clotting all the time, and our thoughts about this microthrombi disease process, we meant to move to that. And so that is something to think about. I personally don't do it in patients that don't have this severe disease process. I think this hypercoagulability is somehow related to the phenotype we're seeing with the lower respiratory tract involvement. And so until they get to the point where they're going to need dexamethasone, I usually don't increase the aggressiveness of my prophylaxis. But as soon as I'm treating them with dexamethasone, I'm also treating them with twice a day Lovenox.
It's great. Thanks so much, Rory, and great commentary. And we'll turn it right over to Manish and to Ethan to lead us out with our information regarding the COVID pilot project.
And before I talk about that, Rory, I'm wondering if you can answer two questions that I think were interesting in the chat. What about if you're sending people home? Would you consider either steroids or anticoagulation in folks that you're discharging?
So anticoagulation, no. I think it's purely the risk benefit only becomes good enough to justify it when you actually have that severe disease process. Steroids, I'm a little more open to. I think the big hesitancy for steroids was in the RECOVER trial. There was a trend towards harm in the patients that weren't hypoxemic. That's a subgroup analysis that it's really hard to make a lot of. We have a huge kind of safety history of steroids, through many disease processes. So I've often thought about giving someone a short course of prednisone I'm sending home, or dexamethasone. Again, I think from most of the patients are going to benefit are the ones you want staying in the hospital. I think this becomes a real question if we do start having a wave where we actually have trouble with beds, and we start discussing that intermediate group, or that moderate risk group, which are the patients who don't desaturate at rest, but when you ambulate them, they desaturate. And as you guys are going to talk about, coming up with some process that we can send them home and follow them closely over the next few days to see the course of their illness. That group, I think I would give steroids to going home, and usually just a course of prednisone like we would for asthma.
Yeah, great. Thank you for answering those questions. So we wanted to talk a little bit about capacity and other things that we can be doing to try to increase our capacity. We're full, and I think things may get worse. And I think there's certainly been times where I've cared for patients where I've been on the fence and I've wanted to send somebody home, and I'd be willing to send them home if I could get them a fingertip pulse ox device and knew that they would have some form of remote monitoring. So we're in the process of developing a pilot program to be able to do just that. And this is it? Am I sharing the slides? Is that coming across? Okay, cool. So we're speaking about individuals here who, just to define the individuals we're talking about, COVID patients, who either individuals who you have a high pretest probability for, or those who test positive, who fall into either a low risk group or a moderate risk group. A low risk group are those where you've seen them, you think they're okay to go home, and they have a resting in an ambulatory sat of greater than or equal to 94%, and a moderate risk group of those in whom you think are clinically stable, they feel okay going home, have a resting sat of greater than or equal to 94% and an ambulatory SAT of greater than or equal to 90%. So just to talk briefly about these definitions before we talk about the pilot program. The pilot program is developing a process to be able to get these individuals a fingertip pulse ox device while they're in the emergency department, and then connecting them to Ethan's team with remote patient monitoring. And so this is essentially just putting together parts that we already have within our system. The hope is to establish this program very rapidly and to establish it safely, and in this first phase, learn to see what works and what doesn't work. And so what we're proposing is establishing a program, hopefully by the end of this week, where if you're working clinically and you have an individual who you deem is safe to go home, is COVID positive, has a smartphone, you can give them a fingertip pulse ox device and order referral to home monitoring. This is an order that already exists within the EMR. Yeah, you can see that right here, referral to home monitoring. This will prompt an order to go to Ethan's team, who currently on the back end within 24 hours will get this order and connect with the patient. When they connect with the patient, they push an app out to their smartphone that allows the individual to engage with a clinician. And Ethan, maybe I'll pause there and maybe you can talk a little bit more about the remote patient monitoring program.
Yeah, sure. Thanks, Manish. So I posted into the chat a RISE module for RPM that's a little bit more information than most people need, but does give you a broader sense of what the program looks like, both from the patient perspective and also what the clinicians monitoring RPM will be seeing. One addition is that referral to home monitoring order. I think that Greg Marchand and team are going to relabel it referral to COVID home monitoring, just so it's a little bit more clear what it is that we're talking about here. This order is available throughout the system, so it's not just ED based, but inpatient and primary care and all kinds of people can refer to it. We've taken 15,000 referrals. So far, we've enrolled 5,000 patients. At any given time right now, there's about 165 to 180 patients enrolled. They're currently getting a 16-day loop of daily engagements via that mobile app that are asking them primarily symptom-based questions and not collecting physiologic data. So the addition here from a monitoring perspective is the addition of the physiologic data, which means obviously they have to have a device to capture that physiologic data. Right now, it's the staffing that I have available for this is a combination of nurses, medical student volunteers, and nurse practitioners, staffed 8A to 8P, 7 days a week. The addition of probably a handful of people who fall in this category any given week is not going to be that big of a burden, but Manish and I have spoken about whether or not we need to have sort of through the night 24/7 coverage, or if that's something we're sort of managing another way. Manish, I don't know if you want to go in a little bit further, and then we'll talk about actually distributing devices, because that's actually obviously important.
Yeah, and so if we can make this work for this first week, again, we would just be connecting individuals who are already going home. And so again, that connection will hopefully occur within 24 hours. What this allows us to do is for all of us at our individual hospitals to work through our processes of like, where are we going to store these pulse ox devices? Do they have batteries in them already? Who's going to show the patient how to use them? Where is that, order within MedConnect of how to make this happen? And then it allows Ethan on the back end to shorten that time, because we want to be in a place where when we send patients home, we have them connected real time to the remote patient monitoring. The ideal is prior to the patient leaving the emergency department, the app is already downloaded on the phone. They've already engaged with the remote patient monitoring clinician, so they know how the app works and how and the usability of it. And they've put the fingertip pulse ox device, so they know how it all works. That kind of gets us into phase 2. So our hope again in that first week is we sort through all the kinks. We start to collect some initial data on how well this works. When we look at phase 2, we talk about expanding this potentially to some individuals who, again, where you look at them and you say, man, you look really good, but when you ambulate, your SAT drops to 92%. I'm not sure how I feel about that. And individuals where you can give them this device that allows them to check their fingertip device and know that they'll have contact with another clinician. When we talk about scope, so You heard Rory refer to a database that we have. We have a database of 1,000 COVID patients that were cared for at Hospital Center in Georgetown that we've worked on over the last 6 months to put together with a number of students at Georgetown. And we looked through those data. And just to give you a sense of the number of people that fall into this low category group, this greater than 94% ambulatory, greater than 94% resting sat, as it is currently, we send home 82% of those patients. So the vast majority of those patients were already discharging. Among the individuals who are hospitalized, there's a small portion that go on to need oxygen. And so the point there is there is a small group, maybe somewhere around 10% of individuals who are currently hospitalizing who potentially could go home. But we know that there's a portion of those patients who are going to come back, and we want to, again, develop a safety net to identify those individuals and have them come back safely. So let me pause there. Ethan, is there anything else you want to add now?
Yeah, actually, I just want to talk a little bit about devices, just to give people a sense of timing of that. In anticipation of sort of making this available, we went ahead and ordered 500 COVID mini kits. It's basically a pulse ox and a digital thermometer managed by one of the country's largest RPM logistics manager, a company called Trupalo. They have a bunch of kits on the shelf that they're also shipping to Mayo and Kaiser. And we said, hey, what are you guys shipping to other health systems? And they said this, and I said, give us 500 of them. So probably Wednesday, each of you should be receiving at your admin offices and your EDs somewhere between 50 and 60 devices to get us started, so that at least you'll have some in hand to get us underway. And then I think as we mature the program, we'll probably have to do something more sophisticated than sending it to vice chairs in the admin office.
Yeah, I mean, and along those lines, as we work to push this out this week, from a time perspective, again, our hope is to go live Thursday, Friday, collect data for a week, and then potentially expand into phase 2 the subsequent Friday or Monday. So one of the things that's going to be really important for us is to have a local champion, a champion at each place.
Just responding to a question that was in the chat there, which is MedConnect discharge instructions. So my team is putting together the patient information and then MedConnect discharge instructions that Greg Marchand will help us kind of paste into there. And that'll kind of go along with that. And obviously there's a fair amount of work to do to create that linkage that's necessary. Right now at the 24-hour mark, a lot of folks are sort of given this as an option. At the 24-hour mark, we have about a 35 to 40% enrollment of people who are offered it, because it's entirely voluntary, and we're mostly talking about low risk patients. So obviously we need to move for folks that were on the fence about keeping in the hospital. They need to be connected to that service before they're really leaving. So there's a fair amount of work necessary to do that, and my team's taken on most of that work to make sure that we have the documentation and processes in place to make it easy.
And if I can add one more thing, as Ethan and I work towards designing the process, we want to make it as seamless and easy for the very busy ED clinician, so that it's one order, and Ethan's team on the back end is doing a lot of the coordinating, and then also potentially coordinating patients to additional services that they could be using at home.
Hey, Manish and Ethan, this is Dave Hager. A couple of questions. One I saw come up on the chat, and Manish and I talked a little bit about this offline, but can you just speak to the finances of this? I understand that initially at this stage, there's going to be no charge to the patient. We're not billing for this. They're essentially being given these packets. So based on that, there's no need to worry about insurance at this stage. And then one question I had is there any attempt going to be made to recover these supplies, or these are given to the patients with the expectation that they will keep them for eternity?
Both good questions, Dave. No attempt at this point to recover supplies. Basically, the price point for this is pulse ox plus digital thermometer plus some of the logistics handling of it, about $31 a kit. So certainly in the early stages of this, not a big deal at all. And if it's going to actually bend the curve on capacity, well worth that investment. Remote patient monitoring is a billable service for the diagnosis of COVID. So if you actually do enough work over the course of a month, both collecting physiologic data and checking in with the patient, there is billing opportunity for it. But it varies a little bit by payer. And I think if we mature this process, we could potentially consent patients for billing for it, but still offer it payer agnostic, with the idea that there's the possibility of recouping some cost in some places, basically just to minimize loss. But so there's a little bit of opportunity for that, but the price point for the devices is low enough that it's not worth reclaiming them.
Okay. I received a couple of questions in the chat, so I think it's probably worth rebroadcasting it. Basically, are we also considering setting up home O2? I would say that in these patients, they're so undifferentiated and we don't know what the direction they're going in. If somebody needs home O2, I think they need to be hospitalized. It's very different than someone having stayed in the hospital for 24 or 48 hours, where we have a lens of kind of knowing what trajectory they're taking. I would say if you think that somebody needs or is a high likelihood that they're going to need oxygen, they need to stay.
Yeah, we're working with the hospitalist team, hospitalists and home care, to do that home O2 for patients who've been on nasal cannula for several days, established stability, but you need to get them out of the hospital because they're stable, they're not getting more interventions. Then home O2 and monitoring with home care nursing involved. But I think I would agree with you, Manish, trying to get it executed out of the emergency department, both logistically difficult and also a set of risk. And I think, Jonathan, to address one of your comments that you made is, we see as failure a patient coming back to the emergency department. I think the goal here is, we know we are going to get at or beyond our capacity here, and that the vast majority of these patients will actually be okay, but we need to actually create a mechanism to find the ones who are not and bring them safely back, and recognize that that's something we will expect. We just need to put the mechanisms in place to do so safely.
Yeah, a lot of the data on home oxygen that people are starting to look into it is after that initial 24 to 48 hours to watch the patients and see if they're getting worse. So it is not that we should be seeing a patient with a saturation below 90 and sending them home from the ED, because that we have seen that can result in badness.
So really great discussion and great points, and a lot of reframing of our thinking. We've covered a broad arc today, starting with vaccines and vaccination, going into the foundations of ED evaluation and the critical care aspects. So a huge thank you to all of our panelists for sharing their expertise and for joining today's conversation. And a huge thank you to all of our participants, over 70 strong. Thank you for joining us and for your questions, your engagement, and sharing your thoughts as well throughout the course of our discussion today. We'll go ahead and conclude here. Hope everyone stays safe and stays well during the holidays. And thanks so much for joining us. Keep an eye on your inboxes for another MEP pop-up learning session soon. Thanks, everyone.
Thanks, John.